I'm Dr. Robert Jones, and in this video we're going to go over how to assess for the presence or absence of hydronephrosis. Renal colic. About 3 to 5% of the population will experience nephrolithiasis sometime during their lifetime. Half of these individuals will have a recurrence within 10 years. Males are predominantly affected, and the classic presentation is going to be radiating colicky pain with or without hematuria. Now, with ureteral colic, what are you going to be looking for with ultrasound? You're going to be looking for the presence of unilateral hydronephrosis. You may or may not see perinephric fluid due to minor calyceal rupture. You may be able to find hydroureter. You may get lucky and find the ureteral stone, although this is not the primary goal of the study. And you may see decreased or absent urine jet on that side, depending on the degree of the obstruction. Now remember, hydronephrosis refers to dilatation of the collecting system. You have to prove that that's what you're looking at. So you want to make sure that you can connect the minor to the major calyces and into the pelvis. Hydronephrosis can be caused by either intrinsic or extrinsic ureteral obstruction. So unless you see the stone, you can't say definitively why the hydronephrosis is there. However, in most cases, you're able to clinically put the picture together. But here you have a patient with severe hydronephrosis. You've got connection of the minor and major calyces into the pelvis. You also have a small amount of perinephric fluid here due to rupture of one of the minor calyces. So let's take a look at the different grades of hydronephrosis. First, you have mild, which is just a very mild dilatation of the renal pelvis, but you don't see any significant dilatation of the major or minor calyces. Now with moderate, you get a little more fullness within the renal pelvis, but you still have a nice look at the parenchyma surrounding the area. With severe hydronephrosis, you can see that in addition to the dilation and fullness in the pelvis, that you're able to see back into from the major into the minor calyces. Now with severe chronic hydronephrosis, what ends up happening is you end up getting thinning of the renal parenchyma. So here you can see a large degree of dilatation of the renal pelvis as well as the major and minor calyces and thinning of the renal parenchyma. This is due to a chronic severe hydronephrosis. Now, which of these are you going to be more likely to miss, or most likely to miss? It's going to be at the extremes. So you're going to be very likely to miss minimal to mild hydronephrosis or even chronic severe, because you're going to look at the chronic severe and go, there's no way that could just be hydronephrosis. So those are going to be the two that you're going to be most likely to miss, and we'll go through ways to avoid making those mistakes. So let's start with severe hydronephrosis first and work our way back. So here you have a coronal view of the right kidney. So you can see here you've got minor and major calyces all connecting together into the renal pelvis and down into the ureter here. Some call this the bear claw sign, but this is a fairly typical appearance of severe hydronephrosis if you cut through the renal pelvis and can therefore connect the minor to major calyces into the pelvis. If you're off axis, this could potentially look like multiple cystic structures, and you want to avoid that. Now here's a transverse view of a patient with severe hydronephrosis. So you can see anterior, posterior, patient's right, patient's left. There's the gallbladder over there. And what you're seeing here is you have significant fullness and dilatation of the renal pelvis, but also of the major and minor calyces. You can see how these all connect as you sweep through the renal pelvis. Note, even with severe hydronephrosis, if you're off axis to the renal pelvis, you could potentially miss this. Therefore, you've got to sweep through the entire kidney. Here's another patient with severe hydronephrosis. What you can see here is the connection of the minor into the major calyces into the pelvis. So by angling up and down, you're able to confirm that these structures all connect and that this is the collecting system. Here's another patient with severe hydronephrosis. Now on this one coronal slice, you could look at this and say that they've got multiple cystic structures. However, doing a sweep through the kidney, you can see that these areas all connect and that you have the quote-unquote bear claw sign. You also can see that there's thinning of the renal parenchyma. So this is a patient with chronic severe hydronephrosis. You can just see right there how these all connect in from the minor to major calyces and into the renal pelvis. And you can follow a little bit there into the ureter proximally. So let's stop here for a second and go over a key point. The collecting system should always appear anechoic. If there's echoes within the collecting system, that either represents blood or pus. So you want to make sure that you have your gain and power set correctly, but if you see echoes within the collecting system, you have to assume that this is either blood or pus. Here was a patient who had a subacute distal ureteral obstruction but came in febrile vomiting. Yes, they do have hydronephrosis, but there's also a layering of echogenic material within there, and you can also see echogenic material here on the coronal view. So this was a patient that had pyonephrosis. And here's an example of pyonephrosis in a patient with a staghorn calculus. You can see the echogenic material within the collecting systems here. This was a patient who came in febrile vomiting with a known history of a staghorn calculus, but here you can see that there's complex appearing fluid within the collecting system, which is definitely not normal. Let's now look at mild or moderate hydronephrosis. Here you can see a transverse view of the kidney. You can see that there is dilatation of the pelvis. You can also see some of the major calyces here. You can see on the sagittal view that it extends beyond the pelvis into the major and minor calyces here. You can also see that these connect, and you can follow the ureter proximally. This was a patient that had a distal ureteral stone. You can see that the renal parenchyma is not thinned. This is a patient with moderate hydronephrosis. Here's another patient with moderate hydronephrosis. You can see fullness of the pelvis, but some extension into the major and minor calyces here. But you can see that the renal parenchyma is not thinned. You can also see some of the medullary pyramids up here. And here's a transverse view of the kidney, and you can see again fullness of the pelvis extending into the major and minor calyces. So let's stop here for a second and go over a key point. The collecting system should always appear anechoic. If there's echoes within the collecting system, that either represents blood or pus. So you want to make sure that you have your gain and power set correctly, but if you see echoes within the collecting system, you have to assume that this is either blood or pus within there, depending on the clinical circumstance. Here's a patient with a mild to moderate amount of hydro, but as you follow the ureter, you can see here that there is an echogenic foci, which is due to a proximal ureteral stone. You can see on the transverse view that there's, again, hydronephrosis, and there, a second ago, we had the stone in the proximal ureter. There it is right there. So you can see that there's hydronephrosis here, extending from the pelvis into the major and minor calyces. So this is something you want to keep your eye out for, the presence of a proximal ureteral stone. It's going to be easiest to find a stone if it's very proximal or if it's very distal. Here we have a patient with a very large echogenic stone within the renal pelvis here. You can see the echogenic border of the stone and then the clean shadowing posteriorly. And you can see on this cut some mild hydro present. Let's take a look now at mild hydronephrosis. Now here's a patient who has a very mild amount of hydronephrosis. If you take a look, there's some dilatation of the pelvis here, and you can see a little bit of the proximal ureter right in here. This was a person with a first-time kidney stone. They were a little bit on the dehydrated side, and they came in shortly after the onset of the symptoms. It's important to remember that when you see unilateral hydro, the presence of that unilateral hydro trumps the degree of hydro. So the fact that it's there is more significant than what the grading of it is. However, with mild hydro, you're going to be very likely to either pass over it or call it potentially normal renal vessels. So with mild hydro, you're most likely going to want to use Doppler to confirm that, what indeed are vessels and what indeed is hydronephrosis. What you got to be careful of when you set the gain for the evaluation of potential mild hydronephrosis, that you don't have the gain set too high, because then you can have bleeding of the color over the hydronephrosis and end up with a false negative. So you have to be careful of that. Here's another case of mild hydronephrosis. So you can see here medullary pyramids out in the parenchyma, but you can see that there's some dilatation here within the pelvis. Could this be a blood vessel? Sure. If you have doubt, go ahead and put color Doppler on. But you can see in this patient who had a right ureteral stone that there's a very small amount of dilatation within the pelvis here, consistent with mild hydronephrosis. And you can see on the transverse view, you can see the very mild dilatation within the pelvis. So remember, on these it's important that you do sweep through the pelvis, because if you're off axis, it's going to make it very challenging to make the correct diagnosis. Let's take a look at urinomas for a second. This is basically free urine surrounding the kidney due to calyceal rupture, and this should be anechoic, and it should basically follow the shape around the kidney depending on the degree of fluid. And here you can see that this patient has a relatively mild stripe of fluid surrounding the kidney here. This was a patient who had a high degree obstruction from a kidney stone, had minor calyceal rupture, and then ended up with free urine surrounding the kidney. So these are not uncommon to see when performing the focused renal ultrasound. With a phased array transducer, here is a coronal image through the kidney, and you can see that there is a very thin stripe of fluid. You can see here's the liver, here's the kidney, here's perinephric fat. So it's between the perinephric fat and the kidney. This is all retroperitoneal fluid. This was a urinoma in this patient who had a ureteral stone. Here's a patient who has severe chronic hydronephrosis. You can see that the parenchyma is thinned. It should be greater than 15 millimeters, but here you can see that there's dilatation of the renal pelvis that extends into the major and minor calyces. You can also see within the ureter that there's this brightly echogenic coiled structure, and that represents a stent within the ureter. But this was a patient with a chronic severe hydronephrosis and thinning of the renal parenchyma. Now, it's not uncommon to see duplication of the intrarenal collecting system. What you'll frequently see is a band of cortical tissue separating the renal sinus into a superior and inferior component. Here was a patient that had a duplicated renal collecting system and had an obstruction of the inferior collecting system. So you want to make sure that you're aware of this potential anomaly, since it would be very easy then to miss hydronephrosis in one of the systems. So here's a patient with a duplicated collecting system and an obstruction with mild hydronephrosis. You can see that there is dilatation of the inferior as well as the superior system. So here you've got the superior system coming up this way with hydronephrosis, and you've got the minor, or the inferior system here that's dilated also. So just keep that in mind, that these patients not uncommonly may have a duplicated system with obstruction of one or the other collecting system. Horseshoe kidneys occur in about 1 in every 600 kidneys, and it's where the inferior pole, rarely the superior pole, fuse together. And usually these people have no symptoms. Now here's a patient with a horseshoe kidney who has an obstruction due to a ureteral stone on the right side over here. And here you can see the transverse view here showing the exact same image. You can see the horseshoe kidney coming across here, and here you can see the ureteral obstruction. This would be a very difficult kidney to scan as a beginner, but be aware that horseshoe kidneys are not uncommon, and this is what you're going to need to look for when scanning these patients. Now, a pelvic kidney, is due to failure of the embryonic kidney to ascend into the abdomen, and the pelvic kidney is going to lie anterior to the sacrum. This is the patient here who had a pelvic kidney. There's a urinary bladder, and there is the pelvic kidney right there lying anterior to the sacrum. So let's go through a couple of pitfalls. I know we talked already about confusing a vessel as mild hydro, but I want to go over it again since this is something that you're going to frequently have to deal with. This was a patient who was asymptomatic, that we went ahead and that we were doing a training exam on, and it appeared at first that there was some mild degree of hydronephrosis, and here's the transverse view right here. However, when we put color Doppler on, we were able to see that these anechoic areas were vessels, and we made sure that the gain was set appropriately so that we didn't bleed over onto any potential dilated portions of a collecting system. But this was a patient who had prominent vessels that appeared to be hydronephrosis, so you just have to be careful of these. Another big potential pitfall is the presence of an extrarenal pelvis. Here on CAT scan, coronal and sagittal views, you can see that there's dilatation of the extrarenal pelvis, but there's no dilatation of the intrarenal pelvis or of the major or minor calyces. Here's a patient with a known dilated extrarenal pelvis. You can see that there's dilatation here of the extrarenal pelvis, but there is no significant dilatation of the intrarenal pelvis, which if you were expecting in a high-grade obstruction, you would expect that this dilatation would also extend within the intrarenal pelvis, but you don't see that on either the sagittal or on the transverse view here. You can see that the dilatation is only extrarenal. So this was not due to an obstruction. Now here's a patient with a very large dilated extrarenal pelvis. You can see a little bit of dilatation of the intrarenal pelvis, but massive dilatation of the extrarenal pelvis. There's intrarenal pelvis, here's extrarenal pelvis. If you take a look at the transverse view, this seems to provide a better perspective, but you can see right here that there's massive dilatation here of the extrarenal pelvis with only maybe minimal dilatation here of the intrarenal pelvis. This was a trauma patient where this was incidentally picked up on the FAST exam. The patient by CT scan had no obstructive uropathy. This was all a dilated extrarenal pelvis. So you can see that this is dilated at a proportion to what you see here, within the intrarenal region. Okay, so let's take a look here and see who has hydronephrosis and who has a dilated extrarenal pelvis. If you look at this patient on the left here, you can see that there's very prominent fullness of the pelvis, extrarenal. But as you look, there's also dilatation of the intrarenal portion of the pelvis extending into the major and minor calyces. However, if you look at this patient here, you can see that yes, there's dilatation of the extrarenal pelvis, but there's really no dilatation at all of the intrarenal pelvis. This was a patient here who had just a dilated extrarenal pelvis. This patient here has hydronephrosis. So it's important to take a look and compare the intrarenal and extrarenal portions, and this will require scanning both coronal and transverse. This concludes now the hydronephrosis assessment lecture. I'm Dr. Robert Jones, and in this video we're going to be going through some of the key associated findings that you're going to come across during a focused renal examination. Now, staghorn calculi, they're going to account for about 10% of all kidney stones, and frequently they're associated with infections caused by urea-splitting bacteria. Here is a patient with a staghorn calculi. You can see multiple large, echogenic areas within the renal pelvis. This patient almost had a cast-like formation of stones within the renal pelvis, causing both acute and chronic obstruction. Here's a patient with staghorn calculus. You can see within the pelvis that there's a large echogenic area here with clean shadowing. You can also see that there's evidence of severe chronic hydronephrosis because you can see that there's significant thinning of the parenchyma, and you can also see that there's a very large amount of hydronephrosis present. You can see that if you're off axis, that these indeed look like renal cysts. That's why it's important that you sweep through and make sure that the minor and the major calyces in the pelvis all connect. So this is a patient with a very extensive staghorn calculus causing obstruction. Renal cysts will be commonly found during the renal exam, and like with all cysts, they should meet the same criteria. They should be anechoic, they should be round or oval, they should have no internal echoes, and there should be some degree of posterior enhancement. Here's a patient with a very large exophytic renal cyst on the left. You can see that it's round, it's anechoic, and that there is posterior enhancement. Here's a patient that has a very large hepatic cyst. You can see the great degree of posterior enhancement, but there's also a renal cyst here. It's round, it's anechoic, and you can see the posterior enhancement behind it. You can also see, as I said, a very large hepatic cyst also. Now, polycystic renal disease is something that you may also come across during your renal exams. It can be an autosomal dominant polycystic disease. You may have variable-sized cortical and medullary-based cysts, and in most cases, these are going to be bilateral. Here was a patient with polycystic kidney disease that was incidentally detected during a FAST exam, but you can see multiple anechoic cysts. They're round, they're anechoic, they have posterior enhancement, and this patient had them in both kidneys. Now here's a coronal view of the left kidney. This patient has multiple cystic lesions distorting the parenchyma of the kidney. It's important to not confuse this with hydronephrosis. Make sure that as you sweep through the kidney, you verify that these are discrete cysts and that these do not connect like you would expect the minor, major calyces and the pelvis to do. Let's take a look now at some potential masses that you may come across. The important thing as a beginning cynologist using this under a focused application, the important thing to remember here is that it's not going to be your job to distinguish between potentially benign and more serious types of masses. Anything you come across that is not anechoic and does not meet the criteria for a simple cyst requires comprehensive ultrasound imaging, whether it's with that ED visit or down the road, but it's important to recognize this and obtain follow-up. Here's a patient that has a large complex mass seen in the superior pole of the kidney. it's not up to you to have to determine what this is. This ultimately turned out to be a renal cell carcinoma. The most important thing is to recognize this. Note how this distorts the normal border of the kidney here. This is clearly not a simple cyst, and this patient did require follow-up. They got it, and they were ultimately diagnosed with renal cell carcinoma. You want to be careful about confusing a dromedary hump with a potential mass. You frequently see these in the left kidney, and you'll notice this type of a bulge that happens. It's related to the embryologic development of the kidney on this side. And what you'll notice is that these humps will have the same echogenicity as the normal parenchyma. If you have any doubt in the beginning as you're scanning, I would definitely recommend getting comprehensive or follow-up imaging on the patient, but take a look and compare the parenchyma. Notice here that this is homogeneous compared to the normal parenchyma, so this was a dromedary hump here. Now here's a fairly common junctional fold. These are wedge-shaped hyperechoic defects in the anterior aspect of the kidney near the junction of the upper and middle thirds. You'll see these not uncommonly when scanning the kidney, and you don't want to confuse these for a more serious mass. Now, columns of Burton are prominent columns of cortical tissue that protrude into the renal sinus and can simulate a mass. But if you take a look closely, this will have the same echogenicity as the surrounding normal parenchyma. But this may be something that will catch your eye during scanning. If you have doubts as to the significance of it and you're unable to confidently call this a prominent column of cortical tissue, then clearly these people should get comprehensive imaging in follow-up or during their current ED visit. Now, pyelonephritis, if it's uncomplicated, you would not expect to detect any sonographic abnormalities. However, in advanced cases, you may detect altered echogenicity of the renal parenchyma. Here was a patient with a more advanced case of pyelonephritis who has several heterogeneous areas within the renal parenchyma. Here's a patient with an advanced case of pyelonephritis who was imaged due to concern for an obstructive uropathy. What you'll notice here is that the patient does have some free fluid surrounding the superior pole of the kidney, and that the parenchyma in the superior pole appears more hyperechoic, and you can see that same area on the CAT scan. So this was a patient that was admitted for a more complex case of pyelonephritis. But remember, if the ultrasound appears normal, you have not excluded pyelonephritis. Here's another patient who was scanned due to concern for an obstructive uropathy. They were clinically found to have pyelonephritis. As we went ahead and scanned them, we noticed that the patient had free fluid adjacent to the superior pole of the kidney, and we also noticed that the endothelial layer here in the renal pelvis appeared thickened. This is not a normal appearance of the endothelial layer. And as we look at the video, you can see how that extends throughout the renal pelvis. This is not uncommon in more advanced cases of pyelonephritis or renal infections. So this again was a patient with a complicated renal infection that was subsequently admitted. Now, renal abscesses may also be detected during the focal renal exam. This was a febrile patient who we had concern for an obstructive uropathy. Ultimately, on the CAT scan, you can see that there's this fluid collection here that represented a renal abscess, and on the ultrasound, we were able to see that same area. You can see this heterogeneous area here within the renal pelvis. Now, the fact that this was a young patient who was febrile and there was enhancing areas on the CAT scan, we felt that this was consistent with a renal abscess. However, in an older patient or someone who was not febrile and there was no concern for an infection, the presence of this heterogeneous area within the renal parenchyma would warrant follow-up definitely. But this patient was febrile and was subsequently admitted to the hospital for more aggressive medical management due to their more advanced renal infection. And lastly, we'll cover medical renal disease. There's a large number of diseases that will affect the renal parenchyma. Now, the degree of echogenicity does not correlate with the severity of renal failure. The echogenicity of the kidney will be considered increased and abnormal when it's greater than the liver or the spleen. And here you can see in this right kidney that the liver up here is hypoechoic to this kidney or to this renal parenchyma. So you can see clearly that this kidney is hyperechoic. Now, this does not tell you what type of renal failure is present. This was a patient who came in with new onset renal failure as well as flank pain, and the goal was to see if this patient had an obstructive uropathy potentially causing the renal failure. This now concludes the key incidental findings video. I'm Dr. Robert Jones, and in this video we're going to go through how to evaluate the findings of the urinary bladder. First, we can do the exam to evaluate for the presence of urinary retention. By doing this, we will obtain bladder volume measurements, and basically here we're just obtaining 3 orthogonal measurements of the bladder. Again, remember the plus sign and the minus sign. By going into your calculation package, you'll be able to get the 3 orthogonal measurements, and then you'll be able to calculate out and then the volume will be calculated out for you. So this is a nice application, and it's better than placing a Foley in most patients, and I think any patient who gets a Foley for urinary retention or post-void residual would agree to that also. Now, distal ureteral stones. Remember, stones are frequently hung up distally, and therefore you've got the ability to use the fluid-filled bladder as a window and look for these stones. The stones that occur anywhere between proximal and distal in this region here are going to be very difficult to find, but fortunately these stones can be very easy to find. Here we had a patient who had 2 distal ureteral stones. You can see them here on CAT scan, which was ultimately obtained in follow-up. But here you can see a sagittal view of the right distal ureter, and you can see 2 echogenic foci within the distal ureter with clean posterior shadowing. And you can see that this was directly posterior to the bladder, so we were able to use that as a sonographic window. Here's a evaluation, first sagittally, of the right distal ureter, and you can see that here's the uterus here, here's the urinary bladder right here, and here's the distal ureter, and you can see an echogenic stone within the distal ureter. Here's a better look at it right here, and there's some posterior shadowing. But you can see that this causes hydroureter, but it's clearly visualizable directly posterior to the bladder. So this is a great window for looking for these distal stones. And if you see them, that's great. Now you've got a definitive diagnosis. You're able to measure the size of the stone, and this provides great information using this non-ionizing technology. Here's another distal ureteral stone. This one you can see here, it's sagittal, so this is anterior, posterior, head and foot. Urinary bladder's down here, so you're not, right at the trigone where the ureter enters into the bladder, but you can see that using the patient's uterus as a window, you can see the right distal ureter coming in, and here's the echogenic stone with shadowing. So again, it's worth taking a look for these distal ureteral stones, especially if you see unilateral hydronephrosis. Here's a patient with a distal right ureteral stone. So you've got anterior, posterior, patient's right, patient's left. We've got color Doppler on, so we're able to visualize the urine jets. We're also able to see some posterior color here. Here you can just see a little bit of the rim. It's being covered by the Doppler, but you can see here that there's a little bit of an echogenic rim right here. This is called twinkle artifact, which can be used in determining the location of small stones. So we can take a look again at this video. You can see a very blunted urinary jet on the right, and this was a patient that had a high grade obstruction. You can see a good urine jet on the left. You can see some degree of hydroureter here, but the stone is sitting right here near the entrance of the ureter into the bladder. So here's a sagittal view of the same patient. You can see anterior, posterior, head, foot. You can see the ureter here. The uterus here. Vaginal canal down here. You can see the urinary bladder, and you can see a couple things. You can see posterior twinkle artifact intermittently here. You can also see a urinary jet. It was diminished compared to the other side. And you can also see then the echogenic foci here, which represents the very distal right ureteral stone. I'll throw out another application for the focused urinary bladder exam. You can also use this for Foley catheter placement. Here was a patient who came in, had urinary retention, had over 1,326 roughly cc's within his urinary bladder. And here you can see after Foley catheter was placed and urine was drained, here you can see the Foley balloon within the empty urinary bladder. This is a sagittal image right here. Here's a patient who comes in. He just had a Foley placed recently, and he states that it's extremely painful and that he's leaking out of his meatus and thinks that there's something wrong. He's got some urine within the Foley bag. We went ahead and performed an ultrasound. Here in the sagittal plane, what you can see is that there's still urine within the bladder. It measured roughly just under 200 cc's. But you can see the tip of the Foley here, but the balloon is blown up in the prostatic urethra. And that's the reason for the pain and the patient's other symptoms. So you can see the tip of the balloon, or the tip of the Foley, is within the bladder, allowing for drainage, but you can see that the balloon is inflated within the prostatic urethra, and therefore it needed to be repositioned. Lastly, when scanning the bladder, you always want to make sure that you look for the presence of air. Both of these patients did not have Foley catheters placed in any recent time period. The patient on the right here has echogenic foci with dirty shadowing posterior in a non-dependent position. This is consistent with air. You always want to be looking for these ring downs or dirty shadowing from air, because air within numerous locations within the body implies a more serious infection or complication. This was a patient that had an emphysematous cystitis from an emphysematous pyelonephritis. This patient here has air within the bladder. Patient states he felt like he wasn't emptying his bladder and had the constant urge to go. This was a patient with known Crohn's or with known diverticular disease. This patient had a fistula, and that was the reason for the air. You could see the localized thickening of the bladder wall, but we went and did this study mainly to do a bladder volume, and we're able to see that this patient has air, and we're able to subsequently obtain further imaging and determine the cause of that, which in this patient's case turned out to be due to a fistula. This now concludes the Assessing the Bladder video. I'm Dr. Robert Jones, and in this lecture we're going to discuss clinical applications of the focused renal examination. Now, in a patient with suspected obstructive uropathy, if you see positive unilateral hydronephrosis, you can treat as an obstructive uropathy provided no other high-risk findings are present. If they're febrile, if they're elderly, you may want to look a little further before resting your hat on the diagnosis of unilateral hydronephrosis due to an obstructive uropathy. If you don't see unilateral hydro, obstructive uropathy is less likely. However, it's not completely excluded. If patients come in right after the onset of the diagnosis, or if they're dehydrated, you may end up with a falsely negative exam. If you see bilateral hydronephrosis, you want to consider a distal obstruction. Now, it's possible that somebody could have bilateral ureteral stones, but that would be pretty unlikely. And if you see bilateral hydro, saying that they have a single ureteral stone would not make sense. They would have to have something distal, and this could be a full bladder or a pelvic mass doing this. If the patient is at risk for a AAA, then you need to scan the aorta, since remember, obstructive uropathy on the left can easily be due to an enlarged abdominal aortic aneurysms. In women who are pregnant in the second and third trimester, the enlarged uterus can also cause extrinsic compression of the ureter and hydronephrosis. So the presence of a right-sided hydronephrosis in an advanced pregnant state, you have to be careful about calling that an obstructive uropathy if you don't see the definitive ureteral stone. Now, in bladder assessment, you can accurately assess bladder volume non-invasively, so you can do this for the patient that you suspect has a full bladder or is incompletely emptying their bladder and you want a post-void residual. You can accurately identify Foley catheter location. You can identify distal ureteral stones in a significant number of cases. And you can identify complicated bladder infections, but remember, ultrasound does not rule out an infection. So let's take a look at this case. You got a 24-year-old female, sudden onset of right groin pain. She's 24 weeks pregnant, her vitals are stable, and she's afebrile, and her urine shows no sign of blood or any evidence of infection. So if you look, yes, she does have mild to moderate hydro on the right. You can see the pelvis connecting to the major and minor calyces. You can see that the parenchyma has a normal thickness, and you can see that this extends down into the proximal ureter. Do you see a definitive stone? No. Is the hydronephrosis unilateral? Yes. If you look at the left kidney here, there's no evidence of any hydronephrosis as you sweep through the pelvis. So the important thing to remember here on this patient is that she's 24 weeks pregnant. While yes, she may have a ureteral stone, this may also be extrinsic compression of the ureter due to an enlarged uterus. So just keep that in mind. Her history of the second trimester pregnancy complicates the picture a little bit. This patient was admitted due to the intractable pain. She developed vomiting, and on subsequent scanning, a distal ureteral stone was picked up, so this patient did have a ureteral stone. So here's a 32-year-old male, sudden onset of left flank pain. You can see that he's got mild hydronephrosis here. You can see the ureter. You can see the dilatation in the pelvis, and it is mild. And here's a transverse view here, sweeping through the kidney. You have some rib artifact over the top there, but you can see that there's some mild dilatation of the renal pelvis. Based on the fact that this patient had a normal right kidney, you can make the diagnosis of unilateral left hydronephrosis. With the presence of 30 RBCs, his young age, this fits an obstructive uropathy. So this was a patient that we treated as such. He had no sign of any infection or complicating issues. His pain and nausea were well controlled, and he was discharged home to follow up. Let's take a look at this case. 84-year-old male, left flank pain. Appears comfortable after he was given narcotic analgesia. He has stable vitals and is afebrile. Right kidney is normal. If you take a look at the ultrasound on the left here, the patient does have mild hydronephrosis. You can see the proximal ureter here. You can see some mild dilatation of the renal pelvis. The most important thing to remember on this patient is that he's got obvious risk factors for having a AAA. He was somewhat obese, so you couldn't feel a pulsatile mass. This patient had an aortic ultrasound performed, which ruled out the presence of a AAA. So just want to bring that point up. I know we've done this several times, but remember, flank pain in an elderly person or someone at risk for AAA, you've got to rule that out before settling on the diagnosis of an obstructive uropathy. Here we have a 36-year-old female, right flank pain and fever, prior history of kidney stones. Her left kidney is normal, so you go ahead and scan her to look for evidence of an obstructive uropathy. What you notice is that there's a small amount of free fluid, cephalad, to the kidney here, so the patient has what most likely would be a urinoma. But the patient also has a heterogeneous appearance to the renal parenchyma. It's hyperechoic in the superior pole. This, in context with the fever, would go along with a more complicated form of pyelonephritis. And this was a patient that was subsequently admitted for IV antibiotics. Lastly, here's a 54-year-old male, hematuria and right flank pain. Vital signs are stable. He's afebrile. As you look at the kidney here, you don't see any significant dilatation within the renal pelvis, but you notice that there's a complex mass involving the superior pole of the kidney. Now, it's not your job to determine what this is, but it's clearly not a simple cyst. This was a patient that needed urgent follow-up. Ultimately, the diagnosis for this patient was renal cell carcinoma. So just keep that in mind. If you see a complex mass, these people all need follow-up. This concludes now the clinical application video of the focused renal section.